Good afternoon, everyone. This is Olivia Marquez, and I'm a research coordinator with Health Evidence. It is my pleasure today to welcome you to our monthly webinar series, and today we will be discussing interventions for preventing elder abuse. What's the evidence? So throughout the session today, we will be posting polling questions through WebEx. Your participation in the polling questions is voluntary and will be anonymous. We hope that this enables your engagement and helps to stimulate discussion throughout the session. So I'll leave this consent slide here up for just a moment. Okay, so just to let everyone know today that after the session, the PowerPoint presentation and the audio recording will be made available through WebEx's YouTube and SlideShare account within the next week. So the links to those resources will also be posted in the chat section. So today we are very pleased to announce that we will be having Dr. Philip Baker here today to present on interventions for preventing abuse in the elderly. And this is from his recent Cochrane review from 2016. So just a few housekeeping items before we begin today. Please use the Q&A and chat section in WebEx to post your questions or comments. We ask that you please send your questions or comments to all participants and not just to the host, but if you do so, not a problem, we will still see your question or comment. Towards the end of the session, we will have an open question and answer session where I will be able to read aloud your questions to our presenter to respond. You do not need to wait until the end of the session to post your questions. You can do so as we are going through today. And for your best connection, we recommend you use a wired internet connection versus wireless. And should you have any problems connecting on WebEx today, you can contact the WebEx 24/7 helpline. So that's posted on the slides in WebEx, and we'll also post that in the chat section for you. For your audio today, we recommend you listen through your speakers, and you can go to Communicate, that's the tab at the top in WebEx, and then click on Audio Connection. So we have our first polling question of the day, and we're asking how many people are watching today's session with you. If you are just yourself, with 2 or 3 other people, or many others who are with you. So again, you can answer this question within WebEx, and then remember to click Submit at the bottom of the screen. So thank you to those who are responding. We have a few people who are joining in some groups, and then the vast majority who are by yourself. So that's great to see. Thank you. So today we'd like to give a special thanks to our Health Evidence team who has helped to bring this session to you today. There's a large team of us who help to work to keep health evidence current and maintained, as well as coordinate this monthly webinar series. So for those of you who may be unfamiliar, Health Evidence launched in 2005, and we are a comprehensive registry of systematic reviews evaluating the effectiveness of public health and health promotion interventions. We provide over 90,000 visitors access per year to over 4,800 quality-rated systematic reviews. We provide the links to the full text, the plain language summaries, and podcasts or webinars where available. One of our main goals of Health Evidence, in addition to making research evidence on the effectiveness of public health interventions more accessible, is to make it easier for professionals to use evidence in decision-making. So the value added for using health evidence is that we save you time. We have done the work for you to screen and appraise each review within our registry. We screen all reviews for relevance to public health and keep our repository up to date by constantly searching relevant databases. At any given time, we're no more than 1 to 2 months behind the publication dates. We have done the work for you by critically appraising all reviews through a transparent process whereby you can actually click on the full quality assessment for each review within the registry and see our rating based on each of our 10 assessment criteria. So healthevidence.org also has a variety of tools and supports for evidence-informed decision-making online. And throughout the years, many users have informed us that our tools and repository are easy and simple to use. So here, before we get started today, we'll just review the model for evidence-informed decision-making, which consists of 5 components that you can see on this diagram. Traditionally, public health practitioners and decision makers consider evidence about community health issues and local context, existing resources, and community and political climate when making decisions about programs and policies. However, it's become more apparent that considering evidence about research may be more challenging. So that's that purple part of this diagram. As such, the Health Evidence webinar series is designed to identify research evidence that's relevant to public health decisions. And today we'll be hearing about the evidence for particular interventions, which helps to fill in that purple section of this diagram. And here we have the evidence-informed public health wheel, which illustrates the steps involved in evidence-informed practice. The wheel is a guide for practitioners and decision makers to determine how to address a particular issue by systematically incorporating research evidence in the decision-making process. So today we'll hear about how Dr. Philip Baker has worked through the first 4 steps here in order to help with the decision makers with the remainder of the 7 steps. So before we move into our next slide, we'll ask how many of you are familiar with PICO-S. And again, just making sure that you hit submit at the bottom of your screen. So we have about almost a 50-50 split between those who are familiar and who are not familiar, so that's great. PICO-S is a way for you to structure your questions in a defined set of evidence-informed decision-making, and it involves defining who the population is that you are interested in, what the intervention is that you want to know about, or the exposure, the comparison group, if any, and sometimes this is a bit difficult to obtain within the public health realm, and any specific outcomes that you are looking for. Sometimes, where this S is at the end, it's also important to identify a particular setting that you might have in mind. So this could be a school or community setting, for example. And the value of a PICO-S question is that when you have an issue that arises, you can use PICO to turn this into a searchable question, which allows you to further articulate specific components of the question and helps you to hone in so that you can search for research relevant to your issue or question. Searching then becomes a lot easier and quicker because you can use your PICO-S to relate and identify what research is relevant to you. So we have our last polling question here before we move into the review findings of the webinar. And we're wondering how many of you use systematic reviews to inform a program or service? So always, often, sometimes, never, or you may not be familiar with what a systematic review is, and that is completely okay. Today will help to give a little bit more information on this process as well. So thank you to those who are responding again. We're seeing that we have quite a few of you who are often or sometimes using systematic reviews, and a few who are unfamiliar with what a systematic review is. And that's not a problem. Philip Baker will help to bring much more information onto this process. So without further ado, we'd like to welcome Dr. Philip Baker, who's joining us from the very early morning in Australia today. And he's a professor of epidemiology at is also the Australia Regional Director at the School of Public Health and Social Work in Queensland University of Technology. So I'll pass the ball along to you, Philip. And thank you for joining us today.
Thank you very much, Olivia, for the welcome, and thank you, Dr. Dobbins and the team at Health Evidence for inviting me to present the findings of our Occurrence. Currently, our recently published Cochrane review on elder abuse, and thank you very much, everyone, for taking the time out of your busy day to join in this webinar. So this is you're looking at the cover page of our review in the Cochrane Library, and we've put a Google short there for you if you'd like, which we invite you to have a look at the review in much further detail. But I'd certainly like to acknowledge my co-authors on this paper, Daniel Francis here at QUT in Brisbane, and also my colleagues at the University of Malaya in Kuala Lumpur, Dr. Norin, Sarjar, and Claire. And this research was supported through grants from the University of Malaya and also from the Institute of Biomedical Health and Innovation at QUT. What we wanted to do in this review was to identify specific programs or strategies to prevent or reduce elder abuse, and this is in people over the age of 60 years old. What we wanted to do was look at studies that describe the effects of programs or strategies and summarize the evidence for those programs in or with older people. This issue of elder abuse or abuse of the elderly has become a priority here in Australia with the National Law Reform Inquiry on Elder Abuse, to which the day that this review was published, we had 2 days to submit to the National Inquiry on elder abuse here in Australia, and so we're hoping that this review will help directly influence some of the decisions that will be made here in Australia, but also as we get the share this information more broadly through the webinars, such as in Canada. And just a week ago, I was at this AGC in Atlanta presenting this to their groups as well. As stated earlier, it's really important to begin a review or even a problem that we have in our practice or delivery of services with a clearly answerable question that's searchable. And here you can see our PICO S question, and we've described the population that we search for as older adults, 60 years and older. The intervention are primary, secondary, and tertiary interventions programs, and they're aimed at reducing or preventing elder abuse occurrence. And the comparison is we look for those programs which were no intervention or usual care. Our outcomes we thought were the occurrence or the reoccurrence of reported elder abuse. And the setting, we were looking for programs or interventions that worked with elderly people within their home or within institutions or even broader in the community. We're also looking at secondary outcomes, and these were some of the changes in the effects of interventions, such as the cognitive status of older people and also the psychosocial issues that relate to the carers of older people. Okay, so what is elder abuse? This is a definition that we've been worked with. So it's defined as not just hitting. Some people think, first off, that elder abuse is hitting, but the definition of abuse is much larger, and it includes physical abuse, psychological abuse, sexual abuse. Can also be neglect, so not providing the care that's required, or even financial exploitation. Elder abuse is quite a common problem, but it's often underreported. And it can be a one-off, or it can be a repeated act, or it can be the a lack of appropriate action and care of an older person. Important thing is that it occurs within a relationship where there's an expectation of trust, but instead of the care and support, abuse occurs. The abuse can often come from someone who they know very well or have a relationship with, such as a spouse, partner, family member, the child, or a friend. But it can also be from someone with whom there is a contractual relationship, such as service providers and institutions in healthcare settings. Elder abuse is a common problem, but it's often underreported. The challenge with elder abuse is that it often occurs out of view, in the perhaps in the privacy of the person's home. Very little information is available about elder abuse. Some surveys have been undertaken in different countries, several countries. Public Health Agency Canada has estimated it between 4 and 10%. Surveys in Canada suggest that 1 in 5 people say they know someone who's been abused. Surveys from Australia and South Korea have shown about 6%, but for example, the survey in Australia was done in only one state in Western Australia, and it was very limited. There's evidence that it is a global health issue. The study by Cooper suggesting between 2.7% and 27.5%. More recently, including a paper published, is found elder abuse in Nepal as sitting at 45%. So what this does draw to is that it's a significant public health issue. There is great economic costs, and these include the direct cost to healthcare, so hospitalizations directly from, say, physical abuse, but also relating to the neglect, the provision of social services, legal issues, including the involvement of police and other services. And as our populations age, we would unfortunately be expecting that abuse would increase as there are more older people in the population. Elder abuse is really complex when we try to understand what causes it. It's a result of interactions that occur at various factors of an individual, relationships, community, and social levels. And these can be conceptualized using an ecological models. Factors from each level can interact, which put the elderly person at a risk of abuse. Some older people, especially those who experience disabilities, dementia, and chronic disease problems, rely on others for their support, and this dependence puts them at a greater risk of maltreatment. Also, older people can have low social support. They can experience loneliness and lack of social networks, which also puts them at risk. Often abusers have their own problems, such as suffering mental illness. They have high levels of hostility. They depend on the older person for accommodation and financial support. Or they might be frustrated by the older person's problems, such as dementia. They may also be taking the opportunity to pay back the abuse which they received as a child. In this review, we looked very broadly for interventions which could prevent the occurrence and reoccurrence of elder abuse. We said that we were after any strategies that avoid potential elder abuse or reduce recurrent elder abuse to lower rates of elder abuse in communities and in institutions. And these included educational programs for carers, programs to reduce factors influencing elder abuse, such as anger and stress management, specific elder abuse-related policies, such as those to improve housing, banking, etc., and legislation that are oriented at mandatory reporting. Also, programs that help increase the detection of abuse so that reoccurrence can be prevented, and programs to help those who are abused, such as protective services, and also those programs which could help rehabilitate the abusers. In terms of legislation, looking for programs to increase detection rates for prevention of elder abuse, for example. So we undertook a comprehensive, transparent, and reproducible search strategy, which is well documented in our review. And we undertook the search between August 2015 and brought it up to date in March 2016. We searched, it was a very extensive search. We searched 19 databases on 12 platforms, including multiple disciplinary bibliographic databases. Sometimes you'll come across reference to PICO-T, and T means the type of studies. And we included randomized controlled trials, other comparative designs, such as interrupted time series. And we were looking for programs that were at least measured the outcomes at 12 weeks or longer. So not just a one-off, say, delivery of a workshop and asking questions at the end about attitudes. We wanted to know what impacts the program had over a longer period of time. So we had two authors, so we searched quite extensively, and we had a minimum of 2 authors of the team independently extract data from the reviews, from the studies that we found, and we wanted to know how trustworthy the information was that we were looking at. So we used the Cochrane risk of bias tool to determine how risky or trustworthy the findings were. We used a process called GRADE to describe the quality of evidence that was extracted across the studies, and we used this criteria, which is based on the principles of Bradford Hill for determining the strength of causal relationship. So basically, we wanted to know, do these interventions, do they cause a change in the outcome? So that's why we chose these specific study designs. Not all study designs have the capacity of assessing causality. So when we use these study designs, we wanted to say, well, to what extent does the evidence tell us that there is a causal relationship? So we want to know the likelihood that these programs prevented the occurrence or reoccurrence of elder abuse. This took us quite a bit of time to work all this through because we found nearly 30,000 articles, and that's after we actually undertook a deduplication process. Because we searched all those databases and 19 databases and 12 platforms, many of the articles came up multiple times, but we had to reduce, we got rid of the duplicates and came out with nearly 30,000 unique articles. And we screened through the titles and then and abstracts, and then looked at 231 of these studies in full text. What we came up with was 7 included studies, and one of these was and then 1 ongoing study, so one study that's in progress. And our evidence that we're presenting today is based on just over 1,900 older persons and 740 other people, such as caregivers and family members. These reviews were undertaken primarily in the United States, 2 in UK and 1 in Taiwan. Unfortunately, we found no studies in Canada. When we looked at what interventions were included, we couldn't find any on the topic of legislation for elder abuse. As something, for example, the Australian Commission inquiry wanted answers for, wanted to know what legislation should be put in place, but unfortunately we found none. There was nothing about rehabilitation programs for offenders, and no study examining specific policies for older people. So I said we wanted to know how trustworthy these studies were, the data that came out of it. Most of the studies had some serious problems. I'm sorry, let me just go back here. In terms of the study design, we found that there were 5 randomized controlled trials and 2 non-randomized control and before and after studies. And these interventions looked at were programs that worked with carers. These are, for example, people in a contractual duty of care relationship, but also family members who provided care, and also programs with those people who were abused, who had been identified as abused. Okay, as I mentioned that we wanted to know how trustworthy these studies were, most of the studies you can see here had some serious problems in the methodology which threatened the trustworthiness of the findings. And the categories that we looked at are here on the left. For example, random sequence generation. Was there a fair assignment of the intervention, of who received the intervention or the control group, or received the intervention of the control? We wanted to, so you can see that just under 50% had it was documented that the process was appropriate. Amongst these, some of these design issues are difficult to achieve, such as the blinding of participants and personnel. Most of the studies achieved good follow-up and provided complete data. And also, they reported the outcomes which they measured. So some studies we come across, we find that authors have held back the findings to manipulate what we read, but in this case, we found that the authors of the studies were reporting the findings that they had. Okay, of the 7 interventions, 3 of these were targeted at health professionals, teaching them skills, such as, so these are like professional development workshops. There was 1 recent study on training coping skills to caregivers, people, family members. 1 study sought to improve detection among residents in care facilities, and 2 studies targeted those persons identified as victims and provided them with strategies such as social support. And now I'll just take you through the 7. Just trying to move forward. Okay. Sorry, am I? It's a little bit unresponsive at my end. Here we go. Okay, so I'll begin with describing the HE study. And so this study had it was over an 8-month study, included 112 caregivers, and what they did was provide a program to nearly all, it was primarily females who were caregivers, and sought to improve their verbal and emotional behaviors to older people, and also improve their ability to cope with stress, promote knowledge, and better care. On this aspect, there were 2 studies where the risks of bias associated with the outcome measurement was at high risk, and challenge was the lack of blinding. And so this study was deemed at high risk of bias. So he's reported a statistically significant between-group effect of a net decrease in abusive behaviors as measured through the caregiver psychological elder abuse behavior scale. Certainly there's evidence of those who participated in the training that it increased their knowledge about elder abuse. But the effects of the intervention upon abusive behavior is uncertain, and also remembering that there is a small improvement, but this study had significant methodological challenges which could impact upon the interpretation of the data findings. This study by Richardson did not report a primary outcome of detecting abuse. It involved a one-day workshops over a 10-month period. And again, most of these were female, 77% in the intervention group, 82% in the control, comprised of nurses, care assistants, and social workers, and worked on their knowledge, attitudes, burnout, especially with patients who had dementia. In terms of the finding, At the end of the intervention, the educational, those who participated in the educational course improved, while those with the material declined. However, the differences are negligible when it's adjusted for the baseline differences between the two groups. So they weren't balanced at the beginning. And one of the problems is that the attitudes of the staff towards the were actually quite good to begin with, and very little difference that was brought about by the intervention. So with the attitudes already quite high, the challenge of this study is that would be questioned whether there was much opportunity to improve them. This study is a more recent study. It is a cluster randomized controlled trial where they randomized nursing homes rather than individuals, and was undertaken in New York City and aimed at certified nursing assistants, and it trained them in recognizing abuse and identifying the risk factors. This is about resident mistreatment, so it's a little bit different than some of the other studies. And it involved 3 modules that were aimed at recognizing and then managing resident abuse. It's a 4-week intervention. It had 6 and 12 months follow-up. In terms of the outcomes of this study, it found that there was certainly a increase in the ability to detect the abuse between residents, but it certainly raises the question about does this recognition and also the reporting of it, we're unsure whether it actually led to less abuse. Another study, Bartels, 2005, was a controlled before and after study, and so not randomized. It was a medium intensity intervention, and it was aimed to improve the assessment and service planning practices of clinicians who undertake assessments of abuse and neglect. And there were some claims of improvement by the study investigators, and when we looked at the data that was presented, it could not support the claims that were made by the authors. We actually went and did a reanalysis of the data that they presented in the paper, and found that the program made no difference. This study by Davis, 2001, it sought to prevent. This is one of 2 studies that sought to prevent the recurrence of abuse. And this was a unique program which it was a nested randomized controlled trial. And what it meant was there was randomization and allocation occurring at 2 levels. First, communities were randomized to a public education intervention. And then within those 2 groups, there was a program. People were randomized to either have home visits or usual just left alone as a control. But what happened here was very was actually that those people who had the home visits and social support with social workers and follow-up police, they had much higher rates of reporting of abuse. The challenge with this is that the study was of lower quality and also difficult to interpret of whether it was more monitoring led to the abuse, but but the control groups also had monitoring and follow-up, but not the in-home follow-up. Brownwell 2006, this study also sought to prevent the reoccurrence of abuse using social support groups, a randomized controlled trial in the U.S. I think the best way to describe this study is preliminary or pilot. It involved 16 victims using a structural education program provided in group setting to older women who had family problems. So 9 of the victims received social support with structured curriculum, for example, 2 weekly sessions over 8 weeks. Unfortunately, the study was too small to detect a difference, and it seems that the authors were unconvinced by the approach, and there was never a larger study undertaken. That's our interpretation of that. Okay, this one, Cooper 2015, a newer study. It's a pragmatic randomized controlled trial looking at care-related factors. This is with family members who care for people who have dementia, older people who have dementia, and it ran for 8 to 14 weeks in duration. We deemed it as medium intensity, and they measured abusive behavior, but unfortunately the analysis looks like they didn't have enough people in the study to detect the difference if the program actually made a difference, so we referred to that as underpowered. The program also looked at their coping strategies, and they found that by teaching coping strategies resulted in less anxiety and depression of family caregivers using the HANS scale. So this study was of moderate quality, and it showed an impact upon the carers themselves. So clearly it's helpful to reduce anxiety and depression of family member carers because, as you know, that providing care to older persons who have dementia can be quite frustrating. This is a new study that's in progress. It also involves some of our colleagues in Malaysia, and it's seeking to improve the program itself seeks to improve nurses' detection, so it's a program with nurses, and whether nurses can detect elder abuse, but not just detect it, but manage it, the abuse, and also neglect. So we look forward to this study when it's completed and published. So to summarize our findings, overall there is no strong evidence that programs specifically targeting risk factors actually reduce the occurrence of abuse. We found that there isn't enough evidence to draw a firm conclusion about whether programs aiming specifically to increase detection actually lead to less abuse. So some of these programs focused on detecting elder abuse, but lacked the information about whether they resulted in less abuse. So the evidence does not show that training programs are likely to lead to increase, that the evidence shows that training programs are likely to lead to more screening of older people, and also so screening for their safety and also for neglect. In terms of the programs that are aimed at supporting victims, it's quite difficult to determine which types of victim programs are most effective and under what circumstances. certainly from the one study, it's very difficult to interpret. The authors have suggested that perhaps there were negative, there was potentially negative harmful effects. So we do have to raise that issue of whether these type of programs did increase the abuse by the family members. So there is uncertainty over this approach, over the approaches that were trialed. So some of the terms of some general implications. So there is very little evidence available to guide public health in the provision of services, and this is quite frustrating. So remember that we looked through 30,000 articles, and we read getting close to 200 articles in full text. Out of this, there is lack of evidence, a lack of research that can support which type of approach should be implemented. So caution is So attempts, we do notice that attempts to increase knowledge about abuse and attitudes of caregivers does not necessarily result in improved attitudes or less abuse. So it does increase their knowledge, but we don't know what the net effect is. Education of health providers may increase the ability to detect abuse. The most promising findings of this review is that the education programs of teaching coping skills to family members is likely to reduce anxiety and depression of the carers, which conceivably would lead to less abuse. And again, that study was underpowered to detect whether it led to less abuse. But conceivably, it does look very promising. In terms of policy and practice, one message we should take away from this review is that doing more of a program or combining strategies is not an evidence-informed approach. So just doing more of things or putting things together, we can't say that it's evidence-informed because we lack much of the evidence about what to do. Caution is therefore is needed in considering the programs and attempts to increase knowledge about abuse and attitudes of caregivers does increase knowledge, but not necessarily result in improved attitudes or less abuse. Specialty training of carers may aid in the detection of abuse perpetrated by other residents. And again, the question is, does it lead to less abuse? So we should consider programs to reduce anxiety and depression in caregivers. So what are some of these implications for research? So certainly the challenge was that we came up with a lot less research than we were expecting. And so research is certainly needed to determine if and to what extent programs to increase detection for elder abuse are effective. Need to determine effective programs targeting victims of elder abuse. Very important that when we looked through the body of evidence, we found many studies, articles were describing were like surveys after the delivery of a program, but lacked a comparison either before or with another approach or usual care. And so we didn't have the evidence to say whether these programs established had a causal relationship. So it's really important that new studies be undertaken that have the capacity to say whether there is a causal relationship between the intervention and the outcomes of abuse. There was absence of studies undertaken in low and middle income countries, so that was important. So there was quite a bit of as we pointed out, there were many articles that we read through describing abuse, but few actually answered the question. So that's where we would say that it's really important to avoid wasted research. So try to invest in research that can answer the questions. Many agencies are providing support to older people, such as in Australia we have helplines. And so I think it's important to support these frontline agencies in providing comparative evaluations of their programs to look to see what effects they have. So the findings of this review certainly identify a challenge for policy development. And on a positive note, there is moderate quality evidence that teaching coping skills to family members of those with dementia is helpful. Health professional training does increase knowledge, and it may increase detection, but we need to be careful about making claims whether these programs result in less abuse. And again, poor quality and wasteful research needs to be avoided. And it's quite promising that there is new research underway, and it would be helpful that a priority be given within national funding schemes, for example, to support the research, to look at which programs are effective at preventing the occurrence and reoccurrence of abuse. We really believe it's important to communicate these findings with stakeholders and those people working in public health. And you'll find in Health Evidence a 3-page summary of this review. And the review's been independently rated by Health Evidence as strong, achieving a 10 out of 10 score using the Health Evidence quality assessment tool. And we're grateful for Health Evidence for publishing this summary. In addition, we've undertaken strategies to get the message out that what's been done isn't good enough, that more research needs to be done to identify what works for older people. And so we've undertaken strategies such as this webinar, seminars, and have prepared a podcast that's available in 6 different languages. So I really want to thank you for joining for this podcast, and I'm sorry, for this webinar, and I'd like to be able to take some questions. So thank you.
Thank you very much, Philip. That was a really great review of what the current research shows pertaining to interventions for preventing elder abuse. So now we will allow attendees today to post any questions or comments that they have in the chat or Q&A section. It would be great to hear any questions you have about the review or any comments that you have about the research that was presented. And I'm just looking right now in the chat and Q&A section. I don't see any questions posted so far. So what I will do is move on to the
I see one question.
Yeah, and some of our polling questions to give those who are attending a chance to post some of their questions. So Philip, we do thank you for helping us to fill in that purple section as we post up the model for evidence-informed decision-making. It certainly helps to highlight what currently exists in terms of the research relevant to interventions for elder abuse, and kind of what we've observed as, you know, quite the gap in research pertaining to this field. So very helpful for those who are making decisions in this area. So for those who are still joining with us today, we have a couple more polling questions before we wrap up. And just on your opinion, if the information today was helpful for you in your field. And again, just making sure to submit your responses when you've completed your polling questions. thank you to those who are responding. And we'll leave that open for just a moment longer as we move on.
There was a question of questions. Sorry, would you like to do the question now that's come in?
Go ahead. Go ahead. Thank you. That would be great.
Okay, thanks. There was a question to clarify the risks of bias and whether in the studies is it related to care, health professional, the time frame. I'm not quite sure of the question. Such as burnout. Now, what we looked at these studies, and we've when the study themselves, in terms of risk of bias refers to the way the study was undertaken, and so the quality of the study. And most of these studies were able to follow people up, so maybe even if they had left, data didn't seem relatively complete. So some of the problems with these studies were in their design about the way whether the groups were fair in the way they allocated who was in the intervention and who would be in the control group. So we looked at things such as some of the studies had problems with the way they assigned it, so not maybe saying that they're randomized or not actually being randomized. Also the challenge about whether the participants themselves knew whether they were in a control or an intervention group. So that can be, sometimes you can run a program and not have to tell the, because the intervention is actually with the carers, so you may not be to blind the people and the residents in the nursing home as to which nurses or carers had received the education and who didn't. So some of those, perhaps they could have done a better job at being more objective in their measurements. So that's were some of the issues that we looked at in terms of what we found in terms of the studies having problems measuring. But many of the studies did measure, had quality measures around that could measure burnout. But whether the burnout led to more abuse or not, managing burnout is unclear. I don't see any further questions.
So we have a few more that have come in, and I apologize, Philip, because sometimes they come in different, posted to different individuals on our list. So I'll read aloud some of the next questions that we have. We have one attendee who's asking, did you find any examples of community interventions, so not institutional, aimed at promoting social connections and access to help for seniors experiencing or at risk of abuse? She says there's a lot of focus on age-friendly communities.
We didn't find, that's a very good question. We didn't find any broad programs at communities. There was the one program, actually, there was the one program which had education into the communities and then worked with the people who were abused through, for example, social work visits. And that was one of the studies which they found a higher level of reporting of abuse. So whether it was the fact that more abuse had occurred or whether it was just better reported, it's unclear. Not sure whether that answers the question.
No, that's great, and we can maybe hear back from a user if we know if that helped to answer her question. And we have another question asking, are there any screening tools that seem to be more effective in identifying a senior's risk of abuse based on a patient's history. She said she knows of one in Canada by NICE, or NICE. EASY is the screening tool, but I was wondering if there were others that seem to be more effective in other parts of the world.
Screening tools. I can't really think off the top of my head which what came out in terms of screening tools. There was a tool for resident-to-resident abuse that was used.
That's great. Maybe we can look into that. And Stephanie, if you're still interested in a response, we can connect with you via email afterwards to help elaborate on your question. And we have another question from Lisa, who's a nurse practitioner, and she's just looking for maybe some clarification. She's noted that, in summary, for healthcare providers, training to identify and screening or treating anxiety and depression in caregivers is what you had determined to be effective. She's wondering if she maybe missed anything or if she can get maybe some confirmation on that.
So working with the caregivers, the study that looked at some caregivers with persons who had dementia did show some effect in terms of reducing their the caregiver's own depression and their just trying to think what the outcomes were. So the program that worked with the family caregivers showed effect around their experience. But in terms of whether there was less abuse by those caregivers to dementia patients, to their family members who had dementia, it's unclear because the data that presented was not statistically significant and likely to become because the number of people in the studies was small.
That's great. Thank you for noting that, Philip. Again, that was from one study, so that's, again, highlighting maybe some of the gap in research at this point. And we're just hearing back from the user who had the question about other supports, and she's clarifying that she's interested in finding support for municipal and or neighborhood level interventions to reduce isolation and informational barriers. So it would be great, maybe we can connect with you after the session via email for maybe a little bit more information that we can find on those municipal or more community level interventions, unless you are familiar with any right now, Philip.
The community, well, there were none that met the study design criteria. But what we have done is in the excluded studies list, listed the names of the other studies that we looked at. So I would recommend going to the review itself and looking through the references that are provided of the other studies that are excluded through the study titles to see which of those might have something which would be relevant that they might look at further. But they were not included because they didn't meet the criteria as an included study. But they may be certainly interesting to look at for further information.
Absolutely, that's great to know, and we can follow up as well with some more information about that. So I'm not seeing too many new questions come in at this point. We do have one last polling question for those who are still with us about if you have any planned next steps after you've heard about now the evidence relating to interventions for elder abuse. So if you're planning on accessing the full text systematic review, and again, we have links to that in the chat section, or accessing the quality assessment for the review on health evidence, or considering using, and maybe it's not quite using the evidence, but directly, because we may not have any actionable findings, but consider using the evidence in light that knowing that there is this gap in research pertaining to these interventions, or if you're planning on telling a colleague about the evidence. So any or all of the options that apply, and just remembering to hit submit at the bottom of the screen. So again, thank you to those who are responding, and we're happy to see those who have some planned next steps of what to do after hearing the evidence from this webinar. So just going back to any chat or Q&A questions, and we invite those of you who are with us to still post any questions or comments that you might have about the evidence. And for those of you who are interested in what you can do now, particularly in reference to health evidence, we invite you to visit the website, which is free to use. We have a repository of systematic reviews that are related to the effectiveness of public health relevant interventions. We invite you to register as a user on health evidence, where you can register to receive monthly tailored registry updates, tailored to your preferences of topic areas of interest to you. Or you can sign up to receive our monthly newsletter to stay up to date on upcoming events and public health news, and upcoming webinars that we have as a part of our monthly webinar series. We invite you to share health evidence with your colleagues and follow us on Twitter. We actually post review-related tweets daily, disseminating evidence from systematic reviews within our registry. And we encourage your organization to support and use health evidence. And always, we invite you to provide any feedback that you have about health evidence, or suggest topics or reviews that you would like to be seen featured in our monthly webinar series. It's great for us, and we can help plan to feature those in future webinars. So I don't see too many more questions coming in, but Philip, thank you for the questions or the responses that you've given so far to any of our questions. And I'll remind everyone that we will be posting the audio recording and the slides for this session on YouTube and SlideShare in case you want to listen or share this with your colleagues. So I have one more question coming in from Stephanie, who's wondering if there's no evidence as to which methods are more effective, in what direction should community services concentrate their efforts so that they have the most impact?
Where should you be looking to have the most impact? So the challenge with that is that at present, we're lacking the evidence to determine where the most impact exists. So what we do recommend is that that people do look through the evidence, do design programs, but to make sure that there's an evaluation of those programs that are being trialed. And one of the examples, one study design that we were expecting to see but didn't see, was something called interrupted time series. And this is where there's a series of measurements that are undertaken before a program is provided over a period of time, and then look to see, once the program has been put in place, to see what effects have occurred. So you could do this with one community or a province, but you need some measurements before and measurements afterwards. And that's really the challenge of what we found, is that there's people have just done surveys at the end of providing a program, or just one piece of data So we'd encourage that the case be put forward that when new programs are tried, that some evaluation goes with them. And that's been certainly a challenge here in Australia with the absence of funding that's been dedicated for the research to prevent elder abuse. So I'd really like to thank everyone for joining today, and thank you very much, Olivia, for inviting me to do this webinar.
Absolutely. It was our pleasure to have you present, Philip, especially coming from Australia. It's a treat for us to have you present on this webinar and to help with the dissemination of this evidence. And just a reminder that there is an evidence summary, as Philip described, on the health evidence review page for this systematic review. And it's a 3-page summary which kind of summarizes the evidence and the implications for public health given this research. So I'm not seeing too many more questions coming through, but we do invite anyone to send any further questions that they have to the info@healthevidence.org email. And we can also loop you in with Philip to help respond to any of your questions that you might have relevant to this review. So Philip, thank you for your final words, if you have any last comments to our attendees. And thank you to those who have joined us today.